my name is Michaela Carlson. I serve as the Senior Director of Research at ACLM, and it's my pleasure to welcome you to our Food as Medicine webinar today on policy, research, and reimbursement. We have a disclaimer that we need to share just for you to be able to review, so we'll give you a few seconds to read this. And we do also like to start with just an intro on the 6 pillars of lifestyle medicine for those of you who may be joining us for the first time, or maybe just getting to know the field. So lifestyle medicine is founded on 6 pillars or health behaviors, and those are whole food, plant-predominant nutrition, regular physical activity, restorative sleep, stress management, avoidance of risky substances, and positive social connection. And this is helpful framing for meeting some of our valued clinicians who are going to present today. And we'll share more about ACLM at the end of the webinar. We can go to the next slide. So I also wanted to mention that the theme of today's presentation is food as medicine, and there's a real urgency to address diet-related chronic conditions that has never been greater. And these include type 2 diabetes, hypertension, obesity, and other chronic diseases that are really reaching epidemic levels in the United States and around the world. However, we hold the power to reverse these trends, and it begins with clinician education, and that is why we are here. So I'm going to introduce our speakers today. We have 3 amazing people that we're so lucky to be able to have gathered for them to share with you today. Katie Garfield, JD, clinical instructor at the Center for Health Law and Policy Innovation of Harvard Law School, Dr. Ajay Joseph, director of the Lifestyle Medicine Program and cardiologist at St. Francis Health System, Tulsa, and Dr. Jaclyn Albin, associate professor of internal medicine, pediatrics, and public health at UTSW. So we're really pleased to be able to have our speakers here today. And with that, I'll turn it over to Katie to begin.
Excellent. Thank you so much for that introduction. As was mentioned, my name is Katie Garfield, and my role here today is really to provide an update regarding the policy landscape for food as medicine at both the state and national level. So next slide. As you can see from this slide, over the last decade, we've seen some major shifts in how policymakers view the role of nutrition in healthcare policy. This really goes all the way back to about 10 years ago in 2016 with CMS, the federal agency that administers the Medicare and Medicaid programs, starting to approve large-scale demonstration projects to test the efficacy of interventions like medically tailored meals, medically tailored groceries, produce prescriptions, sort of collectively described as nutrition supports in Medicaid. And then after we saw a couple of these demonstration projects being approved in states like Massachusetts, Oregon, North Carolina, we started seeing in 2021 really the emergence of more guidance and policy from the federal government to really start putting guardrails around these approaches and guiding implementation of food as medicine in programs like Medicaid, Medicare, but also in additional programs like the VA and Indian Health Service. So next slide. So what generally has been the impact of these efforts? Well, first and foremost, we always have to come back to the fact that food as medicine interventions have not historically been a part of sort of standard baseline benefits in federal healthcare programs. This means that federal laws have not required coverage of these food as medicine services. And while there has been a lot of progress in this last decade, that sort of fundamental piece has not changed. Essentially, if we think of the US healthcare system as a house, food as medicine interventions are still not going in through the front door. However, we are increasingly seeing food as medicine services making it in through the windows. And by that, I mean that food as medicine services are making their way into the healthcare system through narrower policy pathways and flexibilities that are typically optional to individual states and health plans in terms of policy. Next slide. as this slide shows, there are a number of these policy pathways available in our sort of two largest health insurance programs, public health insurance programs in the United States: Medicaid, serving low-income individuals, and Medicare, which serves older adults and individuals with disabilities. So, for example, on the Medicare side, while there's no coverage of food as medicine services as sort of baseline services in original Medicare, Medicare Parts A, for that sort of 50% of people that get their care paid for directly through the federal government, there are flexibilities in Medicare Part C, or Medicare Advantage, which is those private health plans that contract with the federal government to deliver Medicaid care. Individual plans in Medicare Advantage have the option to provide food as medicine services as what are called supplemental benefits, which go beyond that standard Medicare package. And on the Medicaid side, states have a variety of options available to pursue coverage of food as medicine. These include things like Medicaid waivers and flexibilities in the Medicaid managed care program. So next slide. But what's perhaps most important is the actual status of implementation of these policies. So let's take a look at where implementation stands, starting with Medicaid Section 1115 demonstration waivers. So Medicaid Section 1115 demonstration waivers are waivers that allow states to experiment with new approaches to Medicaid delivery, such as coverage of new services, new populations, new approaches to care delivery. States must seek CMS approval to operate an 1115 demonstration waiver, and once approved, waivers typically last for 5 years and then must be renewed or extended. Currently, we know that 13 states have approved 1115 waivers that include the provision of nutrition supports, such as medically tailored meals, medically tailored groceries, and produce prescriptions. We also know that there are 3 additional states that are sort of waiting in the wings. They have similar waivers that are pending approval before CMS. Those are Washington, D.C., Rhode Island, and Nevada. On this map, those in yellow are those that are pending, and those that are in red are those that have already been approved. We also know that this map is still growing. At least one state, Maine, is currently circulating a proposal at the state level, which will then ultimately be submitted to CMS. But 1115 waivers are not the only pathway to coverage of food as medicine services in Medicaid. We're also seeing increasing interest in another pathway called Medicaid in lieu of services and settings, or ILOS. This is a pathway that is specific to Medicaid managed care. So under this pathway, states may give approval to Medicaid managed care plans to cover non-traditional services, such as food as medicine interventions, as medically appropriate, cost-effective substitutes for more traditional care. Typically, states are covering these nutrition supports based on the idea that by doing so, they can prevent the need for future services. So essentially, drawing on data that we've seen around things like medically tailored meals, being able to sort of reduce the need for inpatient hospitalizations, emergency room visits, that kind of additional care. So that's how we're seeing that in lieu of idea coming forth. And I will note that we have a forthcoming article that will actually be out next week that's going to take a deep dive into that in lieu of services landscape. So stay tuned on that. We'll be happy to share it once it's no longer under embargo. But in the meantime, I would say that if you want to learn more about sort of what's possible under in lieu of services, a great example of this is happening in Michigan right now, where they have decided to cover a fairly wide range of food as medicine interventions via that in lieu of services opportunity. Next slide. Okay, so what about implementation in Medicare? As I noted earlier, there's still no coverage for food as medicine in Medicare Parts A and B. But Medicare Advantage plans, so the private health plans that deliver Medicare coverage to about 50% of enrollees, have flexibilities that allow them to provide additional non-traditional services such as food as medicine. They have 2 primary pathways available to them to do this. This includes general supplemental benefits and special supplemental benefits for the chronically ill. First, general supplemental benefits. Medicare Advantage plans can use general supplemental benefits to deliver additional, primarily health-related services to the plan's full population or a subpopulation that's similarly situated. based on condition. Roughly 65% of Medicare Advantage plans are offering a meal benefit via general supplemental benefits. Unfortunately, though, current guidance largely limits this pathway to the provision of meals for short duration in terms of food as medicine. So it's really a missed opportunity for those other nutrition support services that we're seeing in other places like 1115 waivers. Then we have special supplemental benefits for the chronically ill, or SSBCI. This is a more flexible category of supplemental benefits that can include really a wide range of food as medicine interventions. However, plans can only provide SSBCI to enrollees that meet a three-pronged test that includes having a complex chronic condition and really needing a high level of care coordination. As of 2025, 33% of plans were offering food and produce as an SSBCI, which has actually been growing over time. So that's up 4 percentage points from the previous year. But the number is much lower on the meal side. So as SSBCI, you can provide a meal benefit for longer duration than is typically allowed under general supplemental benefits. So it provides an option for meals for longer duration. And some plans have taken up that opportunity. We see about 6% of plans offering that at this point. And some of these maps you can see on this slide give you a sense of where that coverage exists. This is from a really great analysis by ATI Advisory that they do every year that can give you a lot of insight into where Medicare Advantage innovation is happening across the country. Next slide. But I know that in some ways my comments up to this point have been limited because I've been really focused on what we do know, what has happened, what policies in place or are actively pending. But in this moment, I also think it's important to acknowledge that there are a lot of unknowns. So I'll just end by briefly flagging a couple of those unknowns that we're following very closely and that may give us more insight into what policy is going to look like over the next couple of years. First, I'll say that we know there may be new opportunities for food as medicine interventions at the national level as a result of the Make America Healthy Again, or MAHA movement. This movement was spearheaded by the new Secretary of HHS, Robert F. Kennedy Jr. Notably, on the day that Secretary Kennedy was sworn into office, we also saw the release of an executive order establishing a Make America Healthy Again commission to make recommendation towards this goal. And it appears that the connection between nutrition and health is a focus of this movement. However, exactly how that focus will be implemented via policy really remains to be seen. We also don't quite know yet where CMS, the agency charged with administering Medicaid and Medicare programs, is headed on this food as medicine concept. Notably, the first CMS guidance regarding opportunities for addressing social determinants of health in Medicaid came out in the last days of the previous Trump administration. And some of the larger waivers in this space, including the waiver from North Carolina, were approved under that administration. However, we also know that CMS leaders recently rescinded recent guidance regarding the provision of nutrition and housing supports in Medicaid. And I want to be really, really clear about the impact of that rescission because I think it's created some confusion in the community. To be clear, the rescission had no immediate effect. It did not roll back any existing approvals, nor did it create any new policies. CMS was very clear in the email circulating that rescission that it did not impact current approvals. CMS was also clear in that document that it plans to continue to consider proposals to cover nutrition supports via Medicaid on a case-by-case basis. But what I do take away from this letter is that it suggests that CMS is currently determining its way forward on this issue. And so it's going to be really important to watch activity closely in the coming months, years, to understand what that's going to look like under this administration. And finally, I think it's worth noting that there are several decisions pending before CMS that will hopefully give us some helpful insight into that future approach. So as I flagged earlier, there are 3 Section 1115 demonstration waivers that include coverage for nutrition supports in DC, Nevada, and Rhode Island that are currently pending before CMS. Given the sort of case-by-case framing in that rescission letter, we think that the decisions on these proposals will give us a much stronger sense of the coming approach. And so I think it's going to be really important to watch their progress. Additionally, this past November, there was a notice of proposed rulemaking proposing establishing coverage of GLP-1s for obesity in Medicaid and Medicare. That is a decision on that proposal is still pending and could have implications for a lot of these types of services in both programs. So next slide, please. We also know that there are a lot of big open questions in Congress that could also have significant implications for food as medicine efforts. First, that MAHA movement that was spearheaded by Secretary Kennedy has also gained traction in Congress, with members of both the Senate and House establishing MAHA caucuses. The exact legislative priorities of those caucuses remain to be seen. However, it's worth noting that food as medicine is quite literally the first bullet on the Senate's MAHA caucus one-pager, which you can see on the right here. These new caucuses could create new opportunities to support food as medicine at the federal level, but again, a lot remains to be seen. And I think it's at the same time, it's really important to acknowledge that we have another major legislative package moving through Congress, and that's budget reconciliation. This package could have far-reaching impacts on healthcare and nutrition in the United States. It is perhaps sort of, if you're going to watch one policy activity right now, this is probably the one I would keep an eye on. Budget reconciliation is a legislative pathway that allows Congress to fast-track legislation related to spending, revenues, and the debt ceiling. And we say fast-track because reconciliation is not subject to certain procedural requirements, including the filibuster in the Senate. As a result, legislation passed via reconciliation only requires a simple majority, so 51 votes to pass. And this is a critical distinction when margins between parties is so close in the House and the Senate. And of course, in the Senate in particular, because of that filibuster rule. Right now, we are in the midst of the reconciliation process. We still don't know what proposals are going to be included in the final legislation. However, it's important to note that the most likely package, the House's approach at this point, would require the committee responsible for Medicaid to propose $880 billion in cuts to its programs. So we are watching the development of that legislation very closely, as it could really have a seismic impact on the Medicaid program, including budgets and patient enrollment. And in the event of budget cuts, states will, of course, have to make really difficult decisions, including for innovative programming like food as medicine. And so, again, I think this is a really, really important process to be looking at and understanding what it could mean for your states, for your patients. So next slide. Oh, sorry, next one. That's showing us where we are in reconciliation. So takeaways. So in this moment of uncertainty, where there's opportunity, but also potential challenges, what do we take away? First, despite significant policy advancements over the last decade, nutrition supports are still not a part of standard benefits in any federal healthcare program. However, policy pathways do exist that allow states and plans to add these services to their benefit packages. And we continue to see momentum around the uptake of those pathways. But we also know we're in a really, really critical moment policy-wise for this movement. Changes at the federal level have potentially created the possibility of new champions in this space. However, we have to acknowledge that there may be tension between that newfound enthusiasm for nutrition and related policy priorities and these other policy movements that are happening, particularly in Congress. So in this key moment with so much uncertainty, what can you do? I would say first and foremost, stay informed. There are many groups doing great work in monitoring and reporting on policy developments at the federal level. A good example here is that I know my center has a newsletter called Healthcare in Motion that really breaks down key changes and proposals as they're occurring that may impact individuals living with chronic illness or disability. And I'm happy to share that link in the chat if helpful. And second, sort of as you think personally about what you can do, I think this is a good moment to be highlighting the progress and impact of food as medicine programming with your institutional, state, and federal leaders. Doing so can really underline the need to continue this work in this moment. And And you can also assess and communicate how other proposals, like things like cuts to Medicaid, could also impact your patients and communities or undercut the good work that you're doing. And finally, you can continue to advance new research and publish. Data is so critical to informing decision-making among plans and states and the federal government right now. So I really encourage you, if you're doing this work, to capture its impact. And so with that, I'm going to go ahead and hand things over to Dr. Joseph, who can talk more about his work in this space.
Thank you, Katie. Thank you, Michaela and the ACLM team for the opportunity. Over the next 10-15 minutes, I hope to discuss a brief timeline about our program, share the key components of our program, some referral mechanisms that we've developed, and kind of share some updates that we're working on the next few months. Next slide. St. Francis is the largest health system in northeastern Oklahoma. Our main hospital is in Tulsa, and we have 4 satellite hospitals and 110 clinic locations. Next slide. Coming to the timeline of our program, our work started in 2020. We started laying the groundwork for this in 2020, first by networking with different hospital systems and programs across the country, learning from them. We spent some time building a team, creating a curriculum, working with our compliance teams, as well as figuring out the logistics of a teaching kitchen pilot program. And I'm quite fortunate to be part of a health system that has been supportive of this since the beginning. We did then launch a teaching kitchen pilot program in October of 2022. This lasted up until June of 2023. We ran about 3 pilot cohorts consisting of about 12 patients in each cohort, about 35 employees from our health system. This then led to the groundwork on beginning work on a lifestyle medicine clinic. We spent about 6 months working on the logistics of a lifestyle medicine clinic, primarily by building awareness about this clinic amongst different specialties. January 2024 is when the lifestyle medicine EPIC referral went live, whereby patients across the health system could be referred by their providers. Next slide, please. Coming to the program itself, it consists of 2 main portions: the lifestyle medicine multidisciplinary clinic and the teaching kitchen program itself. Next slide. Coming to the referral mechanisms that we've been able to build in place, we are getting about 50 to 60 referrals a month as of now, predominantly a lot of them from diabetes, for diabetes from our endocrine colleagues. GI has been referring quite a few patients to us from a fatty liver perspective. My own cardiology colleagues have been referring patients from their practices. Primary cares have been referring to us for blood pressure, help with blood pressure, as well as diabetes. Tulsa has one of the highest rates of preterm labor in the country, and we're working with our OB/GYN colleagues to build awareness about this program, and we have started to see a fair share of referrals from them. Similarly, our neuro colleagues have been referring patients to us from a mild cognitive impairment standpoint. Oncology has a need for a cancer survivorship program, and we're building the foundation for a cancer survivorship program in collaboration with our oncology colleagues. We're also working with our population health team from an outpatient referral perspective. And from an inpatient referral perspective, we're also working with our population health team, building on an inpatient referral mechanism. And what I find so interesting about lifestyle medicine is that it is a field of medicine that can address the pain point that almost every specialty has. Indeed, I actually got a call from one of my urology colleagues about if they could refer patients to us because 5 to 10% weight loss relieves symptoms of stress incontinence. So that's the scope and scale of lifestyle medicine that we are seeing. Next slide, please. The clinic itself consists, it is a multidisciplinary clinic, and referrals are first pulled in by our nurse coordinator, who then calls up the patient and sets up these visits. New patient visits are 40-minute and follow-up patient visits are 20-minute. On intake, we use the ACLM Loma Linda survey. They are asked to fill out the survey in the waiting room, and this survey is what we use as a baseline to kind of individualize their treatment strategies. These visits are billed to insurance using regular E&M codes. In an effort to make access to a dietitian and therapy as seamless as possible, we provide free visits to a dietitian as well as therapists for a year as part of this office visit. Next slide, please. At this office visit, if we feel that our patients are significantly motivated and they want to take that extra plunge, we offer them our teaching kitchen program. The structure of this program is this happens on Tuesday evenings between 5 and 7:30. The format is a shared medical appointment. It consists of 5 shared medical appointments spread out over 8 weeks, every alternate Tuesday. The team consists of a lifestyle medicine physician, a therapist, a professional chef, and an exercise physiologist. Each cohort consists of about 10 to 12 patients, and this happens at our health zone, which is the hospital-owned health facility. Next slide, please. The structure of each session, the first 1.5 hours is dedicated to the teaching demonstration kitchen portion. We divide these 10 to 12 patients into 4 pods with basic cooking equipment and semi-prepared meals. And we have formulated a curriculum that is based on the ACLM Culinary Medicine curriculum. And this is the first 1.5 hours. This is then followed by a 30-minute didactic session. Each day has a specific focus. The first day is heart disease. The second day is strokes and dementia. The third day is cancers. The fourth day is diabetes and high blood pressure. The fifth day is fatty liver and miscellaneous lifestyle-related topics, thereby covering the entire gamut of lifestyle-related diseases. This is then followed by a 30-minute stress management session led by a professional therapist. And in the midst of these 2 hours, each of these patients is pulled out for brief, smart goal-setting encounters, which are then billed to a 99213 as a 99213. While they're in this program, they do get 2 months of free membership to the health zone, which is our health facility. They get a personalized exercise planning session with an exercise physiologist. They do get a course book which details all the subject matter that we'll discuss in each session. We also use a survey for an objective pre and post assessment of self-efficacy skills. This survey was actually developed by Western Wisconsin Health, and I'm really grateful to them for allowing us to use their survey. And I think what we've found to be most impactful is having patient experiences whereby we have patients from previous cohorts come in and share their experiences, thereby just humanizing this whole experience. This whole experience. Next slide, please. This is our picture of our kitchen. What I wanted to stress is you do not need really fancy equipment. This is a really simple arrangement that we have with 4 tables, pop-up tables, with induction stoves and really basic cooking equipment. Next slide, please. We have seen a significant demand for our kitchen program, and to adapt to this need, we are making a change over the next few months whereby our kitchen program will be run by a health and wellness coach. The same format, we're just adding another half an hour of a group exercise session, which would be led by our exercise physiologist. The group would increase from 12 patients to 15 patients, the same structure, 8 weeks. But it would go from, instead of 2.5 hours, it would be a 3-hour session each. Each session would be 3 hours. Next slide, please. As far as the next steps are concerned, we are hoping to increase the days of clinic to 3 days a week from 2 days a week that it is now by July. And if things go well, according to plan, we are hoping to increase it to 5 days a week by the end of this year. We are expanding the teaching kitchen program cohort that we just discussed to 4 cohorts. I did want to mention that we are moving to an out-of-pocket cost from this month onwards, which we are fixing it at a very nominal fee. This group visits, this kitchen program is, hopefully we can expand this to 8 cohorts by August, and we're planning to expand that to 12 cohorts a week by December. While there is a significant groundswell of support for our program, we do realize and recognize the need to build a sustainable business model that truly reflects the value and the cost savings that lifestyle medicine can potentially bring in. For that, we're working with Ellen Brown and her firm Healthcare actually to build out a business model for us and a strategy for the next 3 to 5 years. In that vein, as following up on what Katie just said, outcomes research is extremely critical. And we are working with Lauren Vanderpool and her firm Social Impact Solutions in publishing results from our clinic. Lauren's firm also is working with us in securing grant funding. Grant funding can be a vital adjunct, and especially when you're building programs to kind of develop proof of concept projects. And that is another area that we'll be working with her on. We have been working with a company out of Washington State called Health Motivate, and we're working with them to kind of build a platform that is customized to our needs. And hopefully we should have that up and running in the next 5 to 6 months. And lastly, I want to share about some exciting updates about a food as medicine program that we are hoping to launch in the next few months. Next slide, please. Fresh RX Oklahoma is a food as medicine program that was launched in 2020 by my good friend Aaron Martin, and we are hoping to get more our needs more aligned together over the next 6 to 12 months. Can you next slide, please? The program itself is a 12-month program. It consists of produce deliveries twice a month to these patients. It also consists of education, about 24 sessions, about twice a month these patients get education. And this is also followed up by health checkpoints every quarter. Next slide, please. In the past 3 or 4 years, Aaron's Fresh RX program has already demonstrated significant cost benefits, as you see on the slide. Largest HbA1c reduction of 8.2, a weight loss of 116 pounds, average HbA1c reductions of 2.2. So significant benefits that they've already been able to demonstrate. Next slide, please. What we're working on over the next 5 to 6 months is a model that brings all these pieces together. The local farmer who we're hoping to connect with our lifestyle medicine team, our population health team, bringing in those the local nutrient-dense produce that I did want to mention is being produced using regenerative agricultural techniques. So that's the plan over the next few months, building this model that hopefully we should have up and running in the next 5 to 6 months. Next slide, please. This I wanted to end with a saying from one of my favorite authors. This is a marathon, and we do realize that we've got a long way to go. But this is something that I've seen time and again happening in this 5-year journey that we've been on, and I really hope that this is what comes true for you all as well. If there's anything that we can help, please feel free to reach out. I am available on LinkedIn, and my email address, I forgot to mention that, it's ajoseph@stfrancis.com. Please feel free to reach out to us if you have any questions about this program. Thank you.
Awesome. Okay, I'm going to take us home with what we're doing in Dallas, Texas at University of Texas. And I just want to say, to piggyback off what Dr. Joseph just ended with, is that this is such a massive problem that there is room for everyone who wants to participate. And sometimes we get a scarcity mindset that it's only for the dietitians or it's only for the doctors. And absolutely, you're hearing from doctors today because we have been aggressively trying to shake up the status quo in the way that we deliver care and the way that we're trained to deliver care. And I'm all for that good trouble. But I think that we need to emphasize, like clinical pharmacists that are in the chat, I'm doing research right now with using pharmacy as a tool to get nutrition resources to our low-income food insecure communities. You know, there's so many intersections, farming and all of that is transforming what we're offering in our cafeterias at our medical center. And when you start doing something small, everybody starts to hear about it and wants to contribute and be part of it. And that's, I mean, I really love the way that you ended that, Dr. Joseph, because while we want to hold the tension of the fact that this is hard, it is also beautiful and people get so excited about it. So I come to this perspective as a lover of food. I'm a pediatrician and an internist, and I'm a mom, and I'm also the granddaughter of farmers. So I really believe in the beauty of food and how it impacts our health. And so I hope you can see how I've gone a very traditional training pathway where I was a pediatrician internist for a decade in primary care before I was able to transition to doing this work more full time. But it is possible, and I am really grateful to share just a little bit with you today. So the next slide is really just my initial philosophical moment for you, which is that doing this is different, and we want it to become normal, but it is not yet normal. And I love Katie's reflection that it's the window, the narrow window is how we get in the house, but it is going to cause you to have conversations where people think you don't know what you're talking about or they don't understand. So be prepared for that. You often have to have the same conversation 20 times. Don't expect that a no means no. Go again in 2 months, go again in 2 months, find somebody else to talk to. And it takes that type of tenacity to see progress. So on my next slide, I'm just here to say that we're talking specifically about food and nutrition, but this is about so much more than that. And it hits so many of the lifestyle medicine pillars. So part of the reason food as medicine emerged, which folks have been asking about that in the chat as well, and we can provide some resources to learn more if you're new to this topic. But basically, we want people to have long-term access to food. We want it to be accessible and affordable. We want it to be nourishing. We want it to be tied to the healthcare system so we can actually measure outcomes. But we also know that it's not just about calories, it's about the quality of our diets and how epigenetically what we eat today can literally impact our DNA transcribing and the way it affects our health in the next days and weeks. So improving the quality of our diets can have huge impact. And then we also know food is not just for health, it's connection, it's culture, it's community. And so I want to set that foundation as I tell you about our application in culinary medicine into patient care and how we deliver that and how we bill for that, thinking about how all of these variables are going to have to be a hyper local application for you. So I'm telling you what's working in Dallas, Texas. What it looks like somewhere else might be a little bit different. And then my next slide is really just to remind you that this is not going to make sense to everyone. And some people are really comfortable doing things the way we've always done things. So you do have to push against without being overly aggressive, because you don't want people to think that, that you're not passionate about making it work for your existing patients and for the existing system. So the way that I approached this was through culinary medicine. And the next slide really is just a beautiful spread that is not mine. This is Today's Dietitian magazine. And there was a dietitian who really dove deep on what is culinary medicine? Why is this becoming such a hot thing in medical schools and residencies? And some people misunderstand and think this is just teaching doctors to cook, which it's definitely so much more than that. It's about training them to practice medicine differently and training them to tie food to health in an evidence-based way and to have conversations that are compassionate and understanding with their patients. And so it's absolutely a collaboration. This article highlighted, you can find this online if you're curious, if you just Google the title, but the collaboration, not a competition between physicians and dietitians. And again, to reiterate, there's room for every other health professional at the table too. So how did we build this at UT Southwestern? So my next slide, I just tell you what I call the culinary medicine service line. I made this up, okay? This is not patented. It is not something that we necessarily can tell you the entire playbook, although I use academic publication to share my work as an academic. And I do have a manuscript that just got accepted describing this whole service line concept, and I would love for others to emulate it. We started by saying culinary medicine is an e-consult. So some of you, especially my fellow internists and subspecialists, will be familiar with e-consults. It's a way to get written feedback from one clinician to another, basically. So in the case of cardiology, since Dr. Joseph's a cardiologist, I'm going to pick on him. If I, as an internist, have a question about my patient's echocardiogram, I might e-consult him and say, hey, I need help knowing whether or not this needs intervention. And the patient doesn't actually have to go anywhere or do anything. And Dr. Josephs can write me back a plan of how I should respond. In culinary medicine, this is a physician-dietitian collaborative written consult where we take people to recipes and to very specific food advice. So it might be someone asking, I have osteoporosis and I don't eat dairy foods. How can I get calcium and vitamin D in my diet more effectively? And we would give them specific tips, specific recipes, and then the receiving clinician can then just put that in an electronic medical message back to their patient. I can bill for it, and there's very specific CMS codes for e-consults. And then coaching consults. Our next step was to say, what if we brought people one-on-one and we met with them and we tied it to their chronic medical problems, and we talked about both the medical piece of it, where I, as the physician, am going through their history and I'm helping them understand the role that food plays in health. And then they're meeting with my dietitian colleague and they're getting really tailored feedback, not only around nutrition, but also around food and cooking. And so that's the beauty of culinary medicine, tying both together, the nutrition with the cooking. And then the third thing that I'll share just a little bit about is our shared medical visit model. So on the next slide, you see just an example of how we developed this across the last 4 years. So we started with the e-consult, and I frankly consider that brand building. E-consults do not generate a ton of revenue, but they define something as a clinical intervention. And so before long, we had e-consults and lots of patient charts where it's showing up in the list of visits that they had. Culinary medicine is a clinical service. And that is really what I wanted to define with that. I will share, after we transition, not quite yet, to the next slide, a couple of publications where we described how we built this, if you're interested in trying it out. Then in December of 2022, that is when we started launching in-person clinic consults, and I use traditional evaluation and management billing, and we'll get to that more in a second. And then the third, and really, like, to me, this is like where the work really happens. It's shared medical appointments. They are fun. I leave energized, and I am able to bill such that I cover what a traditional session of clinical practice would cover in terms of reimbursement and covering costs. And then we're constantly trying to figure out what works, what doesn't work, who's reimbursing us, what patients are coming to us, what do they want, what are the gaps in care. And so I'm working with our analytics team to build a dashboard so we can have a real-time evaluation of how things are going. So on the next slide, the top bar is just a graphic of, hey, how long did it take for me to get culinary medicine on my university webpage? I'm not going to tell you the answer to that, but it was a while, and it took a lot of persistence and tenacity that this is something our patients want, and it is something that we as a really comprehensive health system can and should be leading. And then we actually published 2 papers. Both of these are open access. The first one in nutrients is just a very brief feasibility pilot where we tell you a little bit about how we did it. And then we got a lot of requests for more detail. So we went in and did one in the Journal of Multidisciplinary Healthcare quite recently that has cases, and it says, here's what an example e-consult would look like and how we would respond, and how we build this database of physician dietitian-led content. And then going into the second arm, which is, again, what we've been doing for over 2 years now. It's our interprofessional one-to-one clinic visits on the next slide. And how does a patient get to us? And the figure on the left, which this, by the way, was recently accepted for publication, and so we'll be able to share it more broadly soon. But basically, a physician on campus or an advanced practice provider can identify that their patient needs help. And so many of our clinics don't actually have a dietitian. So then they get sent to us and they meet with both a culinary medicine trained physician, which is right now just me, but I'm really working on building out more colleagues. I have 3 colleagues who are passionately interested in growing our team. And then they're also going to meet with a dietitian. Many of them have never touched a dietitian. Who comes to this clinic? It's our patients with hypertension, diabetes, and high cholesterol are the most common. We know cardiovascular disease is what is driving food-related death in addition to cancer. And so there's so much work we can do through lifestyle and culinary medicine addressing those diagnoses. And so when I see a patient in this clinic, I am typically billing a 99215 evaluation and management code on time, because I can bill for my time, I can bill for my dietitian and I's discussion time that we're talking about each patient, and then I can bill for the time that I'm documenting and coordinating care with other physicians and APPs in our system. So this is the one-on-one visits. patients were begging us for cooking classes. We did this for over a year before we launched our shared medical appointment model. But anyone else not have a kitchen at your hospital and you've tried and there isn't one yet? That is our situation. And so to overcome that, we started building community relationships. There's a lot of kitchens everywhere, and you can overcome the gap by making partners with the people who already have access to kitchens that often aren't being used. So on the next slide, you'll see a picture of an empty space. This is at Oak Cliff Bible Fellowship, which is a church on the southern sector of Dallas County, which is where we actually focus our work because this community is underserved, has high rates of food insecurity, and really wants to learn how to get healthier through food. And someone was bringing up a great question in the chat that part of this is about connection to food resources, but food itself is not enough for most people. They need education and they need confidence that they can do this themselves. So we work with optimizing access to SNAP benefits, optimizing food pantry or charitable food system resources, and then sometimes through a partnership with our food pantry, we're able to do some food prescriptions. So Texas is not an Medicaid 1115 waiver state, as you saw. Neither is Oklahoma, where Dr. Joseph is, and we're finding ways forward even when we don't really have the policy support in our states. So this is my team of pastors, students, and my dietitian colleague and myself putting together stainless steel tables to turn this kitchen at a church into a teaching kitchen. And we launched these group visits. We're now on cohort 5, and you'll just see on the next slide, what does it look like? We're meeting in a gym. We're checking in patients. We're sitting at tables in a fellowship area. Then we're bringing our patients into the teaching kitchen. You see one of our medical student volunteers setting up on the bottom left. And then Millette Seiler, who's my dietitian partner, without whom this wouldn't be possible, is teaching and doing demos. And I think this particular day, she was teaching participants how to eat tofu, which they may have never tried before. And I am meanwhile documenting a note on every single patient. We have up to 16 patients in a class, and I typically am billing a 99214 evaluation and management code based on their chronic medical conditions. And then just to wrap up, I want to say that the picture or even a video on the next slide is worth 1,000 words. And so if you want to see what this looks like, we're not going to play this live because it never works when you try to play a video in a webinar and it's 2.5 minutes. But just scan that QR code and it will take you to our website where it's posted. And then it's also on Vimeo if you want to just wait until you get a slide copy later. So as you move forward in figuring out how to do this, I just want to remind you that you shouldn't do it alone. And my collaboration possibility ideas on the next slide just give you maybe a place to start. Do you have a faith-based organization with a kitchen? What about a community center? Our food pantry has a kitchen. Can you partner with a local farmer? Schools used to teach home ec. How can we use existing resources and not reinvent the wheel? It doesn't take a lot to designate a community site as a site of service with a simple lease agreement, and then that can be a place of billing. And it has been working well for us. We get our full contracted rate from all payers, including Medicaid, Medicare, and private insurers. And then my last slide is just a reminder that we're all making this up as we go. So no one can give you a playbook that says that this is exactly how you should do it, but you have to say, how do I get support? Sometimes that's actually grants and investments. Sometimes that means just resources within your institution or your community where someone says you can use this space or you can have this person's time to help build something. And then while you're innovating, don't forget to measure outcomes, because that is how we define the field going forwards. We all have to have outcomes. And then once we know what works, once we know, hey, this is doing it for our patients, we can scale and take it to the next level. And I know that's what all of us hope to see in our future, hopefully before we retire. And then I've just included some ways to follow me or contact me. And back when my children were sweet and pre-pubertal and loved digging in the garden. Thanks so much. I'll turn it over to Michaela.
Thank you so much, all three of you. That was truly inspiring and really exciting. We have a lot of excellent questions in the chat. I did flag a few to answer live, but for our panelists, while I'm going to go through the next few slides, if you want to check the chat, the Q&A rather, out and see if there are any questions you might want to type answers to, that's great. And we just wanted to make sure before we do Q&A that everyone on the webinar had the chance to learn about some of the other resources that are available from ACLM. We do have for a good part of 2025, our Lifestyle Medicine and Food as Medicine Essentials course remains. This offers 5.5 hours of CME, CE, or MOC, focusing on Introduction to Lifestyle Medicine and Food as Medicine. It's free with the code that you can access from this QR code. Next slide. We also wanted to make sure that you're aware that we have not only the Food as Medicine Essentials course, but we have a lot of courses available for CME, CE, and MOC. We have over 65 or approximately 65 course offerings that are accessible through our website under the Education tab. So that's everything from the Foundations of Lifestyle Medicine board review course to the Remission of Type 2 Diabetes and Reversal of Insulin Resistance course to our Food as Medicine series. We also offer CME, CE quizzes based on American Journal of Lifestyle Medicine articles to our members. Those are free of charge. So that's a way to get more CME or CE. And there's a lot going on, so I'd encourage you to go to our website, especially if you're getting to know the field, and check out what the other courses are. We can go to the next slide. And another amazing and free resource is our culinary medicine curriculum that's available for complimentary download. There's no charge for this. This is a curriculum that Dr. Michelle Hauser, our incoming president, developed, and it's intended for medical schools, health professional programs, and other settings. You're able to access it through this interest form, for which the QR code is right here. And we've had over 10,000 downloads to date, and that's something that you can adapt to your setting. But it's a really amazing resource and takes the participants through weeks of introduction to culinary medicine. Next slide. Also wanted to make sure we mentioned that you may want to check out ACLM membership. If you are not already a member, we would love to have you join. Our members are united in our leadership to influence the future of healthcare, inspire positive change, and make a lasting impact on the root causes of chronic disease through the 6 pillars of lifestyle medicine. I feel like our 2 clinicians that spoke today are like shining examples of doing exactly that. It's really inspiring. And we have a lot of other member benefits that are too numerous to list here, but one of them is that we have a lot of complementary resources and tools, handouts for patients and providers that are available to members. You can use that QR code for membership. And next slide is certification. There were a few questions in the chat around certification. That's a whole nother discussion, too much to get into right now, but there are over 8,000 physicians and clinicians globally who've become diplomates of either ABLM, IBLM, or ACLM, and you can get more information about certification from this link. Next slide. And finally, our conference is coming up November 16th to 19th, 2025 in Grapevine, Texas. It's also online, so it's a hybrid event. In person always does sell out, so we encourage you to register as soon as possible if you think you want to come. And we hope to see you there. There's going to be some amazing content. You can use the code here if you'd like to learn more about that. So now we're going to turn back to our speakers. And we have we have 7 minutes left for questions. So I'm going to suggest we do kind of rapid fire answers. Try to keep your answers really concise, and we'll see if we can get through as many questions as possible. And whoever feels like it's your question, just speak up. First question is, any insight on the timeline for the decision of the pending 1115 waivers?
I will say, unfortunately, no. Of course, with the new administration coming in and transitions, it may take longer than normal. Though I will say oftentimes those decisions have taken over a year. And so it's hard to predict when we'll see those answers. But I do encourage folks to follow it closely, because that's going to be our best first insight for these large demonstrations. But before I stop, I want to just underline, though, something that Jaclyn said earlier that I think is so important, is we see a lot of emphasis on those 1115 waivers right now, but the fact that your state hasn't applied for one or doesn't have one doesn't mean that you can't do this work. She was absolutely right that where these efforts start is with individual pilots and partnerships out of between healthcare providers and community-based organizations and plans and CBOs, and it's often a stepwise process. So yes, watch for those 1115 waivers, but don't feel like you have to wait on that to do this work in your community.
That's great. Thank you. So there were some questions about specific CPT codes, and you guys mentioned a few specific ones. Leslie also put in the chat our billable services by clinician tool that is probably really helpful. But I think really quickly, could you just again review the specific codes that you both use to bill for your food as medicine work?
So my answer is pretty simple. I only bill evaluation and management codes on chronic diseases that have a connection to food. So I answered this in the chat for one person: hypertension, diabetes, heart disease, constipation, fatty liver, IBS, celiac disease, food allergy, osteoporosis, osteoarthritis. All of those are related to food. I'm getting a lot of autoimmune conditions getting referred to us, cancer survivors who want to reduce risk of cancer, who have treatment-related problems. So you bill medical conditions and medical complexity, and then the level of service, which for me is typically 99214 or 99215, is going to be based, and those are established codes. You do have to have an established patient status for a group medical visit within a department, and those are going to be based on medical complexity and or time, depending on the circumstance. I bill medical complexity exclusively in group visits. I bill time pretty much exclusively in our one-to-one visits, since that allows me to also bill for time coordinating with my dietitian partner.
Great. Dr. Joseph, anything to add to that?
Yeah, I want to follow up on what Jaclyn just said. I use predominantly time-based billing, which is for the office. I almost 95% use time-based billing, and it's most oftentimes it's 99214. As far as the group, the shared medical appointments are concerned, it's again a time-based billing, and I use 99213s for most of these visits. I did see questions about the fee for our program. And again, this is a trial pilot phase that we are under. We're moving into, and the fee that we've finally agreed on after a lot of discussion was $150 for the entire 8-week program. As you can imagine, it's quite heavily subsidized from the health system. But we did think that $150 would be a fee that would still not be prohibitive for most patients.
Great. So there's some questions. How do you bill for the visit when you offer it at a local community kitchen? And I think where that question may be coming from is they're asking when you don't offer the program at your typical place of service. So you could answer that generally.
This is such a huge hang up for people. You can make any building a site of service, and your health system might resist it. And yeah, I am so grateful that my health system worked with me on this, because I know other people who've basically just been flat out told no, but it's not a real no. It's a we don't want to do it no. So I actually ended up working to write leases, using AI tools, and then worked with my leasing office, who really cleaned them up, and we lease the kitchens as a mutual agreement, which means you do have to pay them a leasing fee. It's a contracted rate by CMS that's defined locally, so you'll have to figure that out locally. But in my area, leasing a kitchen for about 5 hours is $250. So that is one cost that we have to deduct from the fees. I actually had grant funding to pay for it initially, which helped my system with getting that rolling, but we now sustain the cost through billing. And then I also wanted to mention, there were 2 additional billing questions. One is virtual teaching kitchens. Yes, theoretically, those are billable. That makes folks a little too nervous where I'm at, so we have not explored that yet. I personally have used virtual teaching kitchens in research contexts extensively, and have lots of thoughts about that. I think a hybrid model can be great. It is difficult to build rapport and engagement without at least some in-person content. And then the other one, yes, culinary medicine absolutely belongs in pediatrics. That's a bigger discussion, because how do you engage both caregivers and patients? I am a pediatrician. We're actually working to try to expand my model with one of our our pediatric faculty right now. So stay tuned for more.
Great, thank you. Go ahead, Dr. Joseph.
I did see a question about the non-physician staff, full-time versus part-time. All of my our non-physician staff are part-time, spending about, as an example, my therapist spends about 8 to 16 hours a week in the office, and in combination with the office and the program. Same thing goes for my my dietitian. My dietitian is actually way more than that, and our exercise physiologist is about 20 hours a week.
Okay, great. We have like less than 1 minute. Final question. There were a few questions about health coaches, their training, credentialing. Can you bill for them? Can you speak to that if you incorporate health coaches at all?
It is me and one dietitian, so we have nobody else right now.
Well, health and wellness coaching, as of today, from my understanding, does not have CPD codes. There are temporary codes that are being trialed. And from what I understand from Meg Moore from Well Coaches, that in the next few years, we do hope to see CPD codes for health and wellness coaching.
Okay, to be continued. It's now the top of the hour, so we're going to close. Thank you so much. Please feel free to visit our help center and our website if you have more questions, and we hope to see you at a future ACLM event. Thank you to our panelists.